2 o'clock in Brazil. Hello, everyone, and thank you all for joining us today. It's a great pleasure to have you here after the summer break. Summer in Europe and in North America. Here it's winter. On behalf of the Radiologia Society of Rio de Janeiro and OCAD, it's a pleasure to welcome you. And thank you for being here. My name is Aline Serpati, and I'm honored to co-host this session alongside Dr. Hilary Humans, who has been coordinating and moderating this series with me since 2021. This session takes a slightly different approach from the case-based format we have been adopting since 2021. Today, 2 pairs of radiologists and surgeons will present their cases. Dr. Elisabet Hagert, Dr. Marcelo Bordalo, Dr. Jonathan Flug, and Dr. Karan Patel. Together, they will bring us both radiological and clinical surgical perspectives. At the end of each set of radiologists, we'll have a Q&A session. If you have questions at any point during the presentations, please write them in the chat box, and at the end, the speakers will answer them. Today's presentation will be recorded and available on demand on the OCAD website, which is ocadmsk.com, as well as on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you would like to join the OCAD community and access challenging cases, please consider registering on the OCAD website. Hilary has also launched a few months ago the OCAD channel on LinkedIn, where you can check out interesting cases and the quizzes and stay updated about the sessions. So please, Hilary.
Okay, it's my pleasure to introduce the first dynamic duo of Dr. Karan Patel and Jonathan Flug. Dr. Patel is an orthopedic surgeon at the Mayo Clinic in Arizona. After completing his residency in orthopedic surgery at the Mayo, he completed a fellowship in sports medicine at the University of Michigan and another fellowship in foot and ankle surgery at the Hospital for Special Surgery. He currently serves as the head team physician for the Arizona State University women's basketball and gymnastics teams, and also cares for the men's football and basketball teams. Dr. Jonathan Flug is a musculoskeletal radiologist at the Mayo Clinic, Arizona, and Associate Chair of Quality for the Department of Radiology. He completed his residency at Winthrop University Hospital in New York, followed by musculoskeletal fellowship at Hospital for Special Surgery in New York. He's been at the Mayo Clinic since 2017, where he's worked closely with Dr. Patel and the rest of the orthopedics department as a result of their multi-specialty integrated practice model. Just a side note, when we had our inaugural small group OCAD meeting live in Arizona, Dr. Flug actually made it possible by loaning us a projector and a screen for free. So anyway, I'm forever grateful. So you guys kick off the session.
Well, Hilary, thanks so much for that kind introduction. Let me pull up my slides here, and can you see? Can you see my slides?
It looks good.
Right now?
Yes.
Okay,
Yes.
great. So I just want to say, yeah, it was the Mayo Clinic that offered up that projector and screen, and I was delighted to do it. And I just want to say thank you to you and Alina for keeping the OCAD community going. I've been a member since I think 2014 when I was a fellow, and it's just incredible how much I learned from this group and how grateful I am to have this as part of our MSK world. So just going to talk for 2 seconds, just a little plug for our practice here in Arizona. So this is our hospital in Phoenix, Arizona, right on the border of Scottsdale. You could see the Camelback Mountain in the background, and Karan and the orthopedics group, and we're embedded within their clinic in that little building in the middle. We've got another campus down in Tempe by Arizona State with a dedicated sports medicine group, and there's about 6 of us in MSK and 2 to 3 fellows per year. So it's a great little practice we've got out here, and really delighted to be a part of it. So without further ado, going to get started on the case here. So this was a 23-year-old male who presented with right knee pain following a fall during a softball game. And he reported recurrent falls related to chronic ankle issues, which began after an ankle injury in 2016 playing lacrosse. And he describes it as feeling like his ankle gets stuck and then he needs to reduce it to regain mobility. And it occurs when he turns his foot down and in and then has difficulty bringing his foot out and up. So just to show you, he initially was getting his knee worked up, and he did have this Morel-Lavallée lesion related to the fall. So, pretty significant fall that this patient's having. But once that resolved, he moved on to his ankle. So on exam, he had full range of motion, 5 degrees of ankle dorsiflexion and 15 degrees of plantar flexion, full pronation and supination. Negative for generalized ligamentous laxity, and 2+ instability with anterior drawer, and increased inversion on Taylor tilt testing. And so digging back, here are his x-rays from 2016 when he had that initial lacrosse injury. And just want to bring your attention to this ossicle at the tip of the fibula here. He does have some lateral sided soft tissue swelling, but at that time, no fracture, no other, acute bony pathology. And now in 2023, when we're revisiting his ankle, we still see that ossicle. It's probably a little bit bigger compared to 2016. Maybe in retrospect, a little bit of sclerosis kind of at the margins of the pseudoarthrosis there, but no acute bony injury. Ankle mortise is intact and no soft tissue swelling. So he went on to an MR to try and get a sense of what might be causing these issues in his ankle. And standard MR here, so just want to highlight a few things. The blue arrow is showing you that os anterior and inferior to the fibula, and just want you to see the relationship here to the rest of the fibula on these views. And on the PD FATSAT, you see it here with I would say a little bit of edema, but not much. And it certainly didn't jump out on the initial read. And just on these views here, gonna point out the thickened superficial deltoid ligament and absent or maybe scarred deep fibers of the deltoid. And just a few more slices from that MR just to highlight the ATFL and the CFL. So the ATFL is being shown by the blue arrow here, inserts on that ossicle. It was read and interpreted as being attenuated, but not completely torn. And the CFL similarly was read as being attenuated, consistent with some chronic trauma, but not acutely torn either. And just to show you here, I think in retrospect, there's kind of 2 limbs of the CFL, one attaching on the fibula and one attaching on that ossicle there. So, and I'll just show this quickly. This is a little cine clip, through the ankle, just to give you a global overview of how things look. Okay, so he then was referred to ultrasound to assess the mechanism of clunking, and there was a low-lying peroneus brevis muscle on the MR, and it thought maybe there's some sort of perineal instability that's causing his symptoms. So just want to show you my colleague Nervi Dahia, who does our MSK ultrasound, called me when he was scanning this patient and asked me to go over the MR with him and come down and look. And so we actually had the patient inverting his ankle, going in and out of this locked position. And it's a little hard to see here, but this is with him in that kind of locked position. And this arrow is showing you the distal fibula. And then there was this second ossific prominence or a little bump anterior to that would come and go as he did this maneuver. And he could kind of easily do this to his ankle and self-reduce without any pain. So this is just a cine from that dynamic ultrasound, and here's your peroneus brevis and longus tendons. And it was a little hard because his ankle really had some very significant motion when this would happen. So very hard to get a clean cine loop, but the peroneal tendons really didn't seem to be contributing to the clunking or issues with his ankle. But what we did notice on some static images was that in the neutral position, we had fibula, the ossicle, the talus, and some of those attenuated fibers of the ATFL. And then when he was in this locked position, all of a sudden that ossicle was displacing laterally and really moving pretty significantly, causing that second bump, that second prominence. And so because the patient wasn't having any pain doing this and felt like he could tolerate it, we actually brought him back to MR and just did some limited sequences with him in that position. And I think it's pretty remarkable how still he is here. But just to show you now, we do see that ossicle displacing laterally with the motion. So it's obvious his talus is tilting, pushing that ossicle laterally. And then this yellow arrow here is just to show you those completely torn deep fibers of the deltoid. And then what I'm highlighting here is it was really this bone-on-bone apposition between the sustentaculum talus and the medial malleolus that probably was preventing him from completely dislocating in this position. And so here's just a couple more images just showing you in the neutral position versus his locked position. And the blue arrow is that ossicle. And I think you can just see how it is, you can appreciate the instability and the actual change in position that's happening between these motions. So it's really displacing laterally and a bit superiorly or proximally here. And that's what was causing that locking and instability type picture. And so here, just for comparison, this is now a little cine loop through the ankle in that position, just to show you what that ankle looked like. And so we quickly got him off the table once we had those images, and felt like we kind of had a good sense of what was going on and could really correlate exactly what we were seeing with his clinical symptoms. So, Karan, I'll turn it over to you.
All right. Thanks for having me, guys. Really appreciate being here. I'll try not to lower the average IQ in the room too much. Doctor, it's really is a pleasure to get to work with people like Dr. Flug, Dr. Dehia, our whole department. It makes my job incredibly easy. I've learned a lot about MRI and how to read imaging myself. So much so that I feel like if I got out into practice, I'd be able to do it on my own. Maybe that's a little bit of hubris, but we'll go through a little bit of ankle instability. So low ankle sprains are the most common reason somebody goes to the emergency room in the United States. That's how common they are. So I see a lot of patients with low ankle sprains. They come in, they've either partially or completely torn the ligaments. We typically don't get an MRI initially for low ankle sprains unless patients basically have over 6 weeks of symptoms. Tell the patients kind of the RICE protocol and get them into early physical therapy. 95% of those patients are going to go out and be fine. 5% are going to get what we call chronic instability. A majority of those patients are never going to present again, and they're going to manage it on their own in terms of kind of rest, ice, and rehab once they sprain it again. A few of those patients will either come back with complaints of instability or complaints of pain. Typically, I will start patients with a non-operative treatment protocol, which involves a focus on peroneal tendon strengthening and proprioception. That works for over 80% of patients. And if they don't, I usually see them back about 6 to 8 weeks later. If they feel like they're still weak or still unstable or having pain, which is what a majority of patients actually present with, is pain over the lateral side of the ankle, then we discuss surgical intervention. Surgical intervention consists of typically 2 different treatments. And the easiest way to say this is either you're repairing what they have or you're reconstructing. And that decision of repair versus reconstruction is really patient specific, but I have some criteria that kind of I go by. If patients have significant ligamentous laxity, then I'm going to err towards a reconstruction. If patients have had a modified brostrum or a repair prior, I'm going to lean towards and now they have recurrent instability, I'm going to lean towards a reconstruction. If patients have gross instability with a talar tilt on live fluoroscopic stress test greater than 10 degrees or an anterior drawer greater than 10 millimeters, then I will err towards a reconstruction. Otherwise, I will perform a repair, which in my hands is a modified Brostrom-Gould. We're going to address any underlying pathology at the same time. So any perineal tendon work, any deltoid work, things like that. And we'll kind of get into the deltoid maybe a little bit later, but we'll also address any cartilage abnormalities. So we'll go next slide here. So, this is my workhorse for a lateral ankle reconstruction, which is what we chose for this patient because he had gross instability. I take an allograft, typically a semitendinosus. If you're in a place where allograft is not readily available or not used culturally, then you can take a semi-T autograft. It's very easy to do. When you initially go in there surgically, you don't see the ATFL, you don't see the CFL. All you see is this kind of capsular tissue attaching to the fibula. As you peel it off, you slowly start to see where the ATFL was and where the CFL was, but it's almost impossible to know if it was actually torn or not prior to taking it off, and it's impossible to know whether it's attenuated. So when I perform, whether it's a repair or a reconstruction, I'm typically repairing or reconstructing both the ATFL and the CFL as one large capsular structure, almost like they perform a labor repair in the shoulder. So we create a tailored tunnel. It's a blind socket, put about 15 millimeters of graft into that tunnel, and then shuttle it through 2 tunnels in the fibula. The first tunnel is to create the ATFL. As you can see on the top left there, that first anchor, there you go, right there. That's your ATFL ligament, and then as you pass it back down underneath your fibula and back into the calcaneus, you've reconstructed the CFL. You're going to tension this, with the patient in eversion, putting a maximum posterior drawer on it. You can't over tension this because it's an allograft and it will loosen. If you add things like an internal brace, which surgeons have been known to do, so if you ever see suture material kind of passing through this, that could be an internal brace that can capture the tibio-talar joint and cause significant stiffness. But with an pure allograft, you're unable to do that. And so this is my reconstruction. This is kind of my go-to for a majority of patients with gross instability or ligamentous laxity or revisions. You go next slide for me. So these are our post-operative x-rays. And so you can see the blue arrows there on the left are indicating our fibular tunnels. So you have in the fibula, out the fibula, and then you have a yellow arrow there showing your talar tunnel, and then a faint red arrow, the red arrow showing a faint calcaneal tunnel. That's always hard to see. But those are generally the tunnels you should be able to witness. The risk here is that you could fracture the fibula. That's the biggest risk of surgery. And so the fibula is not a huge bone. And so as you're drilling about a 4.5 millimeter tunnel, both sides. You have to make sure they coalesce in the back, but you have to make sure they have enough room in the front so that you don't create a fracture. We'll go next slide, Jonathan. This is our repair technique. So this is a modified Brostrom-Gould. Anytime you see these pictures, typically clinically, what you'll see is the actual repair of an ATFL and CFL. But like I mentioned to you guys, there's a whole capsule that is extending basically from the ATFL to the CFL that make it impossible to kind of distinguish. And so you're repairing that entire capsule back. I use fiber tacks, which are all suture anchors, so you can't see them on the x-ray. I use 3 of them. So I use technically 1 for the ATFL, 1 for the CFL, and I use 1 for my Gould modification, which is where we pull up our inferior extensor retinaculum. And that really creates a robust repair and a little bit more stability. Go next slide. I'll hand it back over to Jonathan.
Thanks. So I just wanted to show a few last things before we wrap up. So that patient did well. We never ended up imaging him again. But this is just a different companion case, a patient who did have a lateral ligamentous reconstruction, and just wanted to show some examples of what that might look like on MR. So the blue arrow here is showing the ATFL limb, and that yellow arrow showing the suture anchor and the calcaneofibular ligament kind of reconstructed limb. And so in this case, the ATFL portion did become a bit hyperintense and thickened, but we felt like was intact, and you can see it coursing from the anchor to the fibula. There's quite a bit of susceptibility artifact at the fibula, so a little hard to see it in the tunnel, but you can see it coming into the bone and out. And then here you see that CFL limb again, and those suture anchors in the talus and calcaneus. And then just wanted to talk very briefly about the os subfibulare, common accessory ossification center at the distal fibula, or possibly related to ununited ATFL avulsion fractures. Here's a gross photo of a specimen. And so just wanted to point out the ATFL and the calcaneofibular ligament, which insert on that anterior part of the fibula, and the ATFL superior to the calcaneofibular ligament. So if you're wondering about these ossicles, it's really when they're anterior, and depending and how large they are, whether or not there's going to be associated clinical instability and ligamentous laxity with those. So those anterior and those large are more likely to be associated with ligamentous disruption. But these are very common, so I wouldn't jump to them being symptomatic or concerning, on every X-ray we see. And then another case I pulled here. This is a patient who actually had a Mason-Oeuvre fracture, but happened to have another os subfibulare, and that's highlighted here with the O. And then just the native fibula is here posteriorly with the perineal tendons. And just to show you, in this case, you can see the ATFL and PTFL inserting on that ossicle. And actually looking at the calcaneofibular ligament, you've kind of got, here in the blue, you've sort of got a split attachment. So part of it's going to the native fibula, and then part of it here is coursing anteriorly on this ossicle. So that's what we have for the case presentation. Thank you all, and here's a little glimpse of the future of our campus. But Karan and I are happy to take any questions. So thank you.
That was very interesting. I have too many questions. So I'll start with asking, in your case with the wild amount of instability, there was a deltoid ligament tear. When do you decide to repair the deltoid ligament or not in the setting of lateral ankle ligament tear?
Yes, that's a good question. I think that question clinically is not answered yet, even in ankle fractures. When do we fix the deltoid? Some people fix it all the time. The guys at HSS where I trained, everybody fixed the deltoid. But again, that's a billable procedure, so there's a little bias there, right? Depending on if you get paid for it or not. So in my opinion, the deltoid should be fixed in patients with lateral ankle instability when patients have associated medial-sided pain that cannot be attributed to kind of an osteochondral lesion or something else that's going on intra-articularly. So while this patient had to have a deep deltoid injury to sublux as much as they did, they had no medial sided pain. And so my preference would then just be to reconstruct the lateral side and see where they were at. You can also look for medial instability. So if the patients describe eversion instability as well as inversion instability clinically, then that kind of keys you off. There's either something going on with the high ankle or there's something going on with the deltoid or both. And so those are kind of when I start thinking about the deltoid reconstruction. And then if I think that it could be a possible contribution to instability, I do a stress test prior to surgery, live with my C-arm, and I check and I evert them and I look at their medial talar tilt as well as their lateral talar tilt. If they have significant medial talar tilt, then if I overtension them laterally, they're going to be tilted out into valgus at the tibio-talar joint. And so if I believe that they could have medial instability, they're always consented for a deltoid ligament repair versus reconstruction. With that being said, I don't think a repair does a very good job. I've been less than enthused about a repair, so my preference has always been to perform a reconstruction of the deep and superficial deltoid.
Thank you. Somebody whose name I don't know, but the first initial is P, is asking the next question I wanted to ask you, which is, we all know that the ATFL has two components. Does it matter to the surgeon if in the report we specify which component is completely or partially torn?
So I will tell you from my perspective, it doesn't matter because even if you tell me it's partially torn and the patient has instability, it's not going, I'm still going to go through the therapy protocol. And then if they get to the point where they're still unstable or having pain, I'll still perform a surgery and I'm going to repair the ATFL. And actually, even if you say the CFL is normal, it's probably going to get repaired as well, because I don't trust that there's not some underlying stretching of that calcaneofibular ligament, because it acts as a continuum, just like a shoulder labrum, right? And so you're never going to fix just the inferior portion of the labrum or superior. You're going to fix that entire labrum down. And so, no, it doesn't matter to me, but maybe it matters to others.
Okay, thanks. Jonathan, I have a question for you. Having
Sure.
personally had a pretty bad low ankle sprain a couple of years ago, I started with an MRI when my ligaments were read as intact, and my ultrasound had such gross instability with tears of the ATFL and CFL without even stressing my ankle. So, that was a teachable moment for me. I mean, have you encountered cases where the ultrasound upgrades the injury compared to the MRI? I mean, what do you do?
That's a good question. I think to your point, this case was very humbling, because when we saw the gross instability, first of all, the deep fibers of the deltoid were initially read as being scarred, chronically scarred, and then clearly they were completely gone. And then the lateral ankle ligaments were read as attenuated. And I think we've looked at this case many times. You can definitely see portions of ligament, but I think if you really go back and scrutinize, you can't see the clear attachment points on the talus and the calcaneus, and so I think they were stripped. It's really made me just do a second look, be a little less confident, and I think we rely on our clinical colleagues, for when to refer to ultrasound, but we're still starting with MR, on all these cases. But I think to your point, it's important to share these cases with one another, and I think we all assume we're very comfortable and accurate on ankle ligaments, but it's just not the case.
Yeah, I agree.
I think the other thing to add is that you get, and an MRI is a static, like you guys know, it's a static picture, right? Your foot's in a neutral position. What happens if you invert your foot? What does a lateral ankle ligament look like when you invert your foot? Yours might have looked normal, but maybe you had a little avulsion, or maybe you had a little bit off your fibula and you couldn't see a fluid cleft tracking. Maybe you didn't have a big effusion that day. Anything could happen. So I think that happens a lot.
Right. I
Yeah.
agree, 100%. Okay. I don't see any other questions. Speak now, or we're going to move on.
Hillary, I'm just curious. I know you have a lot of experience in the foot and ankle. Have you ever seen a grossly unstable os like this?
Not that I know of. I mean,
Yeah.
when I see
Okay.
those, I talk about where I see that, I have seen the case where it seems to be attaching to the talus, but not to the fibula. If I
Mhm.
see an intervening cleft of fluid and nothing really attaching, I've seen cases like that. But,
Mhm.
they're never displaced because the foot's positioned carefully and neutral.
Yeah, and the amount of edema in that cleft and within the os was pretty underwhelming. And I think I like to think there would have been more edema given how unstable it was, but that just
Yeah,
really
but
wasn't the case.
like even in acute avulsions,
Yeah,
you often see very little edema. And,
yeah,
when you're stressing it, you're opening it up. You're not impacting things and rubbing them against each other. So I'm not sure that we could rely on that.
yeah.
Or
That's a
maybe
great
there's
point.
no blood flow in that little os, right? If there's no blood flow, you're not getting edema because, edema is brought by blood flow. So
Agreed.
maybe that's the problem.
Yeah.
Very interesting.
Well,
Thank you.
well,
Oh,
thanks
wait,
so
wait, wait.
much. Oh,
We have one more question. What type of perineal tendon strengthening exercises does Dr. Patel recommend? How much does this tendon strengthening help with lateral ligament laxity and instability?
So that, yeah, the peroneal tendon doesn't help at all with the laxity or instability. They will always be unstable. If you get them to relax, you'll always have a positive anterior draw and positive tailor tilt. What you're trying to provide, you try to do eccentric peroneal tendon strengthening and proprioception. So where your foot is in space with your eyes closed, because the dynamic stabilizers, your peroneal tendons, if they're functioning right, you can really compensate for ankle instability. And you see this a lot in ballet dancers. They don't come in with lateral ankle injury. They come in with peroneal tendon strains because they're ligamentously lax, and they've just been using their peroneal brevis and their peroneal longus to stabilize their ankle their whole lives. And so that's, what we call peroneal overdrive. So it's just a dynamic stabilizer. So basically you just have them do eccentric peroneal tendon strengthening and some proprioception. But a peroneal tendon tear is a sign of a lateral ankle that is unstable. That's one thing that I always look for.
Wonderful. Thank you. Okay.
Okay, moving on to the next speakers. It's my pleasure to introduce Professor Elisabet Hagert. She's a globally recognized hand, wrist, and peripheral nerve surgeon from Stockholm, Sweden. And she's a dual board certified in hand and orthopedic surgery and served as head of hand, wrist, and nerve surgery at Aspetar Orthopedic and Sports Medicine Hospital and clinical professor of orthopedics at Qatar University. She earned her PhD from the Karolinska Institute in Sweden and completed postdoctoral training at Stanford University. Recently awarded Legend of Hand Surgery by the American Society for Surgery of the Hand for her pioneering research and leadership in the field. With over 120 peer-reviewed publications and book chapters and international textbooks, she's ranked among the world's top 2% of scientists in her field. It's also my great pleasure to introduce our next speaker, Dr. Marcelo Bordalo. He completed his medical degree, radiology residency, and musculoskeletal fellowship at the University of São Paulo here in Brazil. He then pursued further specialized training in MSK imaging at both Université Catholique de Louvain in Belgium and New York University in the United States. He also holds a PhD from the University of São Paulo, and he served as the director of MSK Radiology at Hospital das Clínicas and Hospital Sírio-Libanês, both in São Paulo, Brazil. He's currently the chief of radiology at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. Dr. Bordalo is also the editor of the MSK volume of the Brazilian College of Radiology book series and has an extensive academic output with more than 100 peer-reviewed articles and several book chapters to his name. Please, Marcelo and Elisabet, take it away.
Thank you, Aline. Thank you, Hillary. It's a pleasure, always a pleasure being at OCAD. It's such a great community to discuss and interact. So me and Elisabet are gonna talk about peripheral nerve imaging and radiology and the surgical perspectives on it. So we work here in Qatar. It's this small country here in the Arabic Peninsula, just next to Saudi Arabia. And Aspetar, which is a sports medicine and orthopedic hospital, this is Aspetar, and it's embedded in this Aspire complex, which is a sports complex where all the national sports federations are located in the country. So we provide the medical service for all sports in the country, in the Middle East, and even from abroad. It's the great advantage, I think, of working at Aspetar is the strong culture of multidisciplinary collaboration and working with Elisabet. It's particularly rewarding. She's really keen to collaborate with radiology. We developed several protocols on hand and wrist injury and especially on peripheral nerve imaging and peripheral nerve. So we used to call Elisabet Queen Elisabet. She's the queen of hand and wrist surgery, and that's how we call her. This is Elisabet with the radiology team at Aspetar. Dr. Mariam is missing from this picture, and we collaborate in all fields. This is on the left side with our book that we publish on peripheral nerve. On the middle, Elisabet collaborated in this book about the Lacerda syndrome with Dr. Vincent from France. And here it's a cadaver lab we did at Aspetar on ultrasound guided surgical procedures of nerve release. This is Dr. Vincent in the middle. On the far right side of the picture is Dr. Benjamin. He's also collaborated in that Lacerda's book. So it's a great pleasure to work with Elisabet. Now, Elisabet, I'm going to pass to you to start the first case.
Thank you so much, Marcelo, and thank you for that amazing introduction. So basically what we want to talk about today is pain and the role that nerves has in pain and the collaboration that we have at Aspetar. For me to work with Marcelo has transmuted like my peripheral nerve work to an entirely different level. He's just an outstanding nerve radiologist, and I'm very honored to work with him. So pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Next. Marcellus, next slide, please. Thanks. So when we're talking about diagnosing pain in the clinic as a surgeon, it's all about listening. It is about examining, and it's about imaging, because we can actually listen and hear what our patients are saying, and they can give us clues as to what nerves are engaged. Next, please. So this is, if you scan that QR code, you're going to get to an open access publication from International Orthopedics that recently came out. We had a special issue on peripheral nerve disorders, in particular in athletes. And so we've developed a clinical triad consisting of motor, sensory, and pain diagnosis. So we follow that for any peripheral nerve disorder or compression. When it comes to the upper extremity, we have a standardized muscle algorithm that we use for examining and screening for any peripheral nerve disorders. And this includes a scanning for muscle power in the shoulder, elbow, wrist, and the hand. What we're really looking for is what we call the M4 power of muscle testing, and that is power against resistance. And so it's against resistance and gravity. So this is a type of power loss that you actually have to go and search for. It's not going to be evident. You're not going to find it on EMGs or nerve conduction studies. Next, please, Marcelo. After we do a motor test, we look for a sensory exam. And the sensory exam often includes 2-point discrimination. We use the Tinel's test. We use something called the 10 test, which is subjective. The patient will score how they're feeling from 0 to 10 compared to the contralateral side. We also use what's called the scratch or the sensory collapse test, or the SCT. And I'm going through this as I believe a lot of radiologists might not be aware of this. So the scratch or the sensory collapse test was first described by Susan McKinnon and co-workers in 2008. It involves a physical irritant over the level of nerve compression or nerve injury. And when you have the patient seated with the arms adducted to the side, slight external rotation, you push against the arms, and then you scratch over the area of nerve compression. This is an ipsilateral test, meaning that you can use the power testing in the arms, even in the cases of lower extremity nerve compressions. So in the case of a tarsal tunnel, you can scratch over the tarsal tunnel and the arm will fall in. So this is a video of how we do the scratch collapse test. I don't know if we're able to have video sound with that. So we have a patient that is seated. This patient has right-sided, if I remember correctly, right-sided Lacerda syndrome, and which is a proximal median nerve compression at the level of the elbow, and left-sided cubital tunnel syndrome. And so slight external rotation, you push, the patient is trying to resist, you scratch first on the contralateral side, you see that the patient is strong, then you scratch over the affected side, and after you scratch over the nerve, they lose the power to withhold resistance. I think we can go to the next one, Marcelo. And lastly, we test for pain. So once you've delineated the level of nerve compression based on motor exam, you do the sensory testing, including the sensory collapse test, and finally you push where you think the nerve is compressed. Lastly, of course, now imaging is extremely important when it comes to diagnosing nerve compressions, in particular as nerve diagnostic studies with EMG and nerve conduction studies are quite often inconclusive and not very good. So we use high resolution ultrasound and MR neurography. So I'm going to hand over to Dr. Marcelo.
So this is, let's go to the case. So this is the case. Actually, Elisabet, do you want to go through the clinical aspect of it?
Yes, so we had a professional female football or soccer player who came to us from a neighboring country to Qatar. And she was asked to describe, she came with lower extremity pain and pain in both the lower leg and in the foot. We asked her to describe her pain, then she described it as burning over the dorsal foot, numbness on the lateral aspect of the lower leg. She had a feeling of stumbling and loss of proprioception, and she described it as being someone else's foot. So we did muscle testing, and the muscle testing includes testing for common peroneal, deep peroneal, and superficial peroneal nerves. And so what we find on the muscle test is that on her left side, which is the affected side, she had weakness when testing the tibialis anterior. And she had weakness when testing extensor hallucis longus. She also had positive sensory collapse tests. And you can do the sensory collapse test with the legs as well as with the arms. And so what we do is we scratch over the common peroneal nerve because that's where her motor exam indicated she had a weakness. And so you see how her leg is going to all the way over to the other side. But she also, based on her burning and the numbness in her foot, we also suspected that she had a superficial peroneal nerve compression. And so we also did sensory collapse testing for that, scratching over the SPN at the distal aspect of the leg. And you see how that leg is flying over to the side. Lastly, we used kinesiotape. So quite a lot of these nerve compressions are dynamic nerve compressions. And by using kinesiotape to just sort of shift the muscles over the nerve, you can actually restore power and eliminate that positive sensory collapse test. Yeah, let's move on, Marcelo.
So we did ultrasound on this patient. So this is superficial peroneal nerve here at the lower leg. You're going to see it has this normal aspect, and you're going to see it increases the size and decreases the echogenicity. At this point, I hope you all see my arrow here. At this point here, it increases size and decreases hypoechogenicity. So ultrasound is a fantastic method for these very small peripheral nerves. So this is the image, the pathologic image. So this is the thickened superficial peripheral nerve, and this is the fibrous band compressing the peripheral nerve. On the long axis, on the longitudinal axis, this is very well seen. We can see the kinking of the nerve. So this black structure, tubular structure, is the nerve, and you can see this fibrous band compressing and kinking the superficial peroneal nerve. I want to highlight, this is not part of the radiologist day-to-day work. So something that I used to when I start doing these very small nerves is get an aid from e-anatomy. I don't think it's a shame. I think it's a sign of wisdom to look for e-anatomy. I have no share with e-anatomy, but I think it's a very great app to look at anatomy, especially for these very small nerves. Going back to Elisabet.
Thank you for that. So this soccer player had a history of an ankle sprain, and she came to us with almost a 2-year history of pain. And MRI had only shown a small ATFL sprain, nothing else. But if we look at the superficial peroneal nerve where it exits in the lower aspect of the leg, that is actually a place where it can get kinked also in an ankle sprain. So based on the clinical findings and in collaboration with Marcelo and his ultrasound findings, we decided to go to surgery to do a nerve decompression in this case. Now, what we want to do is we want to be very precise when we do our nerve decompressions. Traditionally, nerve decompressions have been done as very extensive compressions, like you release the nerve in the entire path. We don't believe in that concept anymore because we know that after nerve decompressions, you can get scar tissue around the nerve. So we want to be very precise in our location. So what we do is on the day of surgery, the patient will go to ultrasound, and you see that little mark right there. That is what Dr. Marcelo did. So he placed the mark where he, on ultrasound, found the kinking of the nerve. Based on that, I could focus my incision and my exploration of the nerve to that precise point. And so what we're seeing here in that image is that very tubular shape of the nerve. We see a very severe hourglass compression of the nerve, and then the nerve becomes quite normal again. And this is the transverse fibular band that is crossing over the superficial peroneal nerve in the distal aspect of the knee. So that has been released to show the nerve in its compression. And I think it's amazing to see how that image live in surgery is so alike to the image on ultrasound. I saw the patient since she was from a neighboring country. She was actually leaving Doha just a couple of days later, and we're actually 3 days post-surgery, which is what I'm showing. We released the superficial and the common peroneal nerves. And so what we're doing is we're testing the power and asking her about her sensation. So what she is saying, you're not hearing the audio in this video, is that she has had a complete resolution of all of her burning sensation. She has normal sensation. She's feeling the same in both feet. And when we're testing for power in the ankle dorsiflexion, as you can see, she is bilaterally strong. So that power is back immediately after that common peroneal nerve release, both in her tibialis anterior and in her EHL. Moving on to our second case, we have a 28-year-old male who presented to us. He is a professional equestrian and particularly a horse jumper. So he presented with gradual onset of medial knee pain associated with riding. In Feb 23, he went through an MRI that showed a possible medial-patellar synovial plica insinuating into the femoropatellar joint space. He was prescribed no horse riding, physiotherapy. He went through PRP injections. He had no improvement. He then went on to cortisone injection. About 7 months later, he presented with a persistent medial-sided knee pain when riding, pain on walking in stairs. He did a new MRI, and once again, he was seen as having a possible medial patellofemoral plica. He underwent in May 24 a knee arthroscopy, medial parapatellar plica. Everything else looked normal. So the plica was subsequently removed by one of our knee surgeons. He came to me in November of 24, so 2 years since onset, and he described having fatigue when walking in stairs, pain when medially in the knee when riding, standing up in stirrups, numbness in the medial aspect of the knee, doesn't trust his knee, and felt zero improvement after that plica removal. And what we're doing is we're doing that muscle testing again. And so what we're seeing is that he has weakness when it comes to doing hip flexion. And so you would ask, why would he have weakness in hip flexion when we're examining medial-sided knee numbness? Well, due to pain that is elicited from the saphenous nerve, if it is compressed, he will have a pain-inhibited hip flexion. So for our muscle exam, we test for saphenous nerve hip flexion, we test sensation on the medial aspect of the knee, we do the sensory collapse test over Hunter's canal, and test for pain at the level of Hunter's. Marcelo.
So we started with the ultrasound. Here's the anatomy, the saphenous nerve at the distal aspect of the thigh. It locates medially between and the sartorius and the gracilis, and we can see it thicken here on ultrasound. We did the MR neurography. I want to emphasize, in our experience, we're using these double echo the steady state sequences, which is called Mensa in GE and DES in Siemens. I think they have really fantastic vascular suppression, and the nerves are really bright in these images. This is an example of an acquisition in the shoulder of this MR neurography, and the MIP reconstructions, we can see perfectly. This is a normal volunteer with normal nerves. We can see the axillary nerve, we can see the suprascapular nerve, and we can see the musculocutaneous nerve. And this is not one case or another. In every case, we can see these very small nerves with these sequences. And in our case, we can see here the saphenous nerve right after Hunter's canal. There is thickening and increased signal. You can compare with the signal and the thickness within the Hunter's canal on the sagittal MIP reconstruction and on the coronal. So saphenous nerve compressive neuropathy.
So based on the combination, once again, of the clinical exam, long-standing history in an athlete unable to perform his sport, and the findings on MRI, we decided to proceed with saphenous nerve decompression in the thigh. And what we do is we like to do a lot of nerve decompressions in local anesthesia using only lidocaine with epinephrine, because then you can test for the return of power intraoperatively. This is the appearance of the saphenous nerve at Hunter's canal. So you can see that thickening of the nerve, and that nerve is actually quite often thicker than we might anticipate. And so what we do is we test for power intraoperatively. So in this case, hip flexion due to pain. So we can see how weak he is in hip flexion power before release. And then intraoperatively, as soon as we release that saphenous nerve, we test it again, and the power is back on the table. So it's really very rewarding as a surgeon. Instant gratification. We love it.
These were our cases. We want to thank you, and I think we're a little bit late. Sorry about that, but I think we can go to the Q&A.
Yes, thank you very much. Let me see if there is any questions. Hillary, are you there? Oh, so I think I missed it. What was the yes? So what was the cause of the fibrous band in the first case over the nerve in the soccer player?
So that is the natural exit point of the superficial peroneal nerve in the distal aspect of the leg. And so what happened was, due to her ankle distortion, her twist of her ankle, the nerve got stretched, and she had a edema along the nerve. And then what happens is it creates like a fibrosis around the nerve, and it gets stuck. So wherever we are in the body, right? I mean, the nerve goes through passages, tight passages, and these tunnels are aspects where the nerve is going to get stuck. And if we know where the tunnels are, we're going to be able to look for those nerve compressions, both on radiology and clinically.
Great, thank you.
Marcelo, do you typically start with ultrasound and then go to neurography, or it's up to the referring clinician? How do you go about this? Because it seems to me like the ultrasound was diagnostic in both cases.
Yeah. We usually start with ultrasound. As I said, I think ultrasound is the examination for the small peripheral nerves, where we complemented with neurography just because of the learning curve, and to give more confidence for the surgeon. It's easier with the MIP reconstructions for him to see the anatomic relationships, and I think it's more convincing. Don't you agree, Elisabet?
Definitely. I mean, I think we have several aspects in this. And one is that we quite often work with insurance companies, and we have to convince them that they are going to be approving our surgical cases. And so we know that nerve conduction studies and EMGs are going to be negative in these cases. Quite often we don't even ask for them. But if we have both ultrasound and MRI, and they are both indicative of a nerve compression, then we find that the insurance companies are actually approving our cases. That's one aspect. The other aspect is, of course, and when presenting this to the patients or the athletes, that we need to make sure that they are also convinced that we have the right diagnosis. And finally, we're doing it also because we are learning as we go. I think the way we are using imaging in combination with clinics for nerve compression disorders is quite unique. And so we are gathering a lot of material to be able to spread this both to surgeons and radiologists around the world. Wouldn't you say, Marcelo?
Yeah, totally agree.
So there are a couple of more questions. What's the explanation for the scratch test to occur?
That is amazing. So the scratch test is, or sensory collapse test, is just my absolute favorite clinical test. And I believe Marcelo is also using it sometimes with his patients when he's doing the examinations. It's believed to be a monosynaptic protective reflex. Studies have been done on rats showing that there is something called the cutaneous silent period on EMG. So if you have a neuropathy in the paw of the foot on a rat, and you irritate that paw, you will see that there is an inhibitory reflex on EMG. And so it is just a very spontaneous, like a withdrawal type of reflex. And so it causes a monosynaptic, very short inhibition of voluntary muscle control.
Yeah, just to complement what Elisabet said, she taught us to do the scratch collapse test. We usually do it, and for me, this is sorcery because it's always it's incredible how it's positive in the pathologic cases.
Sounds like a fun party trick.
It's amazing. It's absolutely amazing. And then you add the kinesiotape to that. So what you do is you do all these tests, right? The clinical muscle test, you do the scratch test. And then when it's a dynamic nerve compression, you do a little kinesiotaping just to shift the muscles over the nerve. And the power is back and the scratch test is negative. So the patients think our clinics are definitely sorcery.
There's a question from Dr. Malvina. Excellent case presentations, thank you. When would you consider gadolinium for MR neurography in cases like this?
Almost never. Most of them just with these MR neurography sequences, we're able to do diagnosis. We only do GAD if there's a suspicion of a nerve sheath tumor or something like that. But for compressive neuropathies, not at all.
Thank you. Dr. Lait Alairi is asking, do you have a certain protocol to follow for imaging peripheral nerves?
Yes, as I said, for each peripheral nerve, we have a specific protocol. I think the great the bottom line is in what sequence you're going to do the acquisition, in what plane you're going to do the acquisition for that specific nerve. So if it's a long segment of the nerve, we usually do the MR, the neurographic sequence on the coronal or sagittal plane. If it's a small segment, we do it on axial, and always do the MIP. The MIP, when I started as a resident, we had some we weren't so sure about the clinical efficacy of the MIP reconstructions, but I think it's very important. It gives us a very clear general aspect of what's happening. And of course, we always look at the axial. The axial is our workhorse, and we always look at it. But I start with the MIP reconstructions for a peripheral nerve.
And Dr. Brown is asking if you know what's the equivalent Mensa sequence for Phillips.
As long as I'm aware, Eduardo, I don't think we have the steady state in the Phillips, but I'm not sure. I don't work with Phillips. I didn't work. So as long as I'm aware, it's only available on Siemens NG, but I'm not really sure about that.
Any more questions?
Let me just
Okay.
add, as for me as a surgeon, peripheral nerve surgeon, having had access now to working with Dr. Marcelo, who is just like a wizard when it comes to MR neurography, the way he creates, it's art. I send my patients and he gives me art, and he gives me back like everything I need as a surgeon. And it's just incredible. So if you have any like nerve interest at all, the radiologists who are listening today, I hope you're working with Siemens or GE so you can have these amazing sequences that Dr. Marcelo is working with, because the work he's doing is outstanding and it has totally changed my practice.
Okay, great. Any more questions from the audience? Okay, thank you all for joining us today. Thank you, Marcelo. Thank you, Elisabet, Jonathan, Dr. Karan, and Hillary, of course. Our next session is scheduled for October 10th. Mark your calendars, and we'll see you then. Bye-bye. Thank you very much.